live from high atop the Aubrey Plaza in beautiful downtown Wilmington, Delaware. We are the Podcast Pediatricians. I'm Rob Walter, and I'm going solo today for this special Pediatric Obesity Debate Edition from Hot Topics Pediatrics at Disney World on July 18th. Matt skipped Hot Topics this year. You know, he was off doing math things, listening to blues, playing cards, not doing his EMR charting. But today, you'll hear two wonderful speakers talking about severe childhood obesity and medication versus surgical options, and what a golden age it is to practice pediatric obesity medicine with all the new treatments and options. Obviously, we lean on lifestyle, nutrition, exercise, but for the severe cases of especially teens and young adults, all these new options and treatments have made a huge difference. Dr. Nancy Crimmins, pediatric endocrinologist and professor of pediatrics at Cincinnati Children's and leader in their pediatric obesity program, is our first debater. She also was a 4-year dual varsity athlete in beautiful Franklin College in Indiana. And our second speaker is Dr. Asif Mahmood, medical director of the Adolescent Bariatric Surgery Program of Advent Health in Florida, and he's boarded in pediatrics, internal medicine, and obesity medicine. Now, to set this up, first Dr. Crimmins gave 3 talks, one on early obesity, one on obesity, morbidity, screening and management, and then one on pediatric obesity medications, the GLP-1s. And then Dr. Mahmood discussed the role of bariatric surgery in pediatric severe obesity. So before we get to the epic debate, I thought I would give you some highlights of their talks to set up the discussion. But first, our disclaimer. We are sharing our personal opinions on pediatric care. Always talk to your own pediatric caregivers about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care. To start off on early onset obesity, Dr. Crimmins stressed that we need to focus on these youngest children who are overweight. The strongest genetic risk for excess weight shows up in these early ages, and feeding behaviors and food preferences develop during this window in early childhood. Now, the best definitions of obesity under age 2 are weight for length greater than 97.7 percentile or 2 standard deviations. For over age 2, BMI greater than 95 percentile, and severe obesity over age 2, 120% of this 95th percentile. We all know the prevalence of obesity is skyrocketing. It's 12.7% in U.S. children 2 to 5 years of age, though, and severe obesity in this young age is 1.8% of children. And it's kind of shocking, but not surprising. 90% of children who are obese by age 3 are obese as adolescents. So we should stop saying that they will just thin out. And the BMI of children with severe obesity at age 6 starts to diverge from the growth chart as early as 4 to 6 months of age. When we're doing those 4 and 6 month visits and 9 months visits, that's where we're often seeing the most severe obesity starting, and maybe we can try to do something about it, but it's hard. Early obesity risk factors include small for gestational age, and with it can be genetic factors of holding on to calories and insulin resistance, and the other side of the ledger, large for gestational age. Of course, breastfeeding protects against obesity, and she did mention that baby-led weaning, early studies do seem to help with obesity. Various tips she gave included that parents often add cereal to the bottle to help them sleep. But this really increases obesity risk, which led to the discussion that when we do need to add something to the milk, which often is for reflux, we should use gel mix instead of using cereal because there's much fewer calories if you thick with it. I think about a quarter of the calories. We should take a careful feeding history on these very young, heavy children, have them walk through the day, especially if there's multiple caregivers like grandma, and make sure you ask what they're drinking, Again, juice should never be given. Once you take the pulp and the skin out of a piece of fruit, it's pretty much just sugar. We should also try to address parental obesity. And yes, being in the office with parents who are very large and their child's large, it is tricky. You should ask about parental heights and ask the parents as appropriate how old they were when they started to gain weight quickly. And if there's a family history of obesity-related diseases like type 2 diabetes and cardiovascular disease. She made a point about picky eaters. And we always talk about food sensitivity. But if a child used to eat a specific food and then stopped eating it, that's a behavioral issue, not a sensory issue. And also she wanted to debunk the big bone theory. When people say they're just big bones, a lot of us don't like to show the growth chart to families for different reasons, but sometimes these early ages you should show them, and you can draw a line in the weight curve and just show how it's going way above the 95th percentile. I would add, I particularly don't like to do this with teenagers. It still makes me think that we're creating some kids with eating disorders. She mentioned about the website myplate.gov, which you can utilize to show a usual meal and portions, and I've actually gone on that and copied a few of the pictures of the plate, and I do give that out. The genetic component, MC4R mutations are autosomal dominant and the most common form of monogenic obesity in 2 to 5% of severely obese children. So consider looking for these if there's hyperphagia, accelerated linear growth without neurodevelopmental findings. And testing for these genes are available. I would usually utilize our geneticist colleagues on that. Of course, that makes me think of Prader-Willi syndrome. And just remember, in that syndrome, you're actually usually failure to thrive the first couple of years of life with short stature, motor delay, hypotonia, classic facial features, and the hyperphagia comes after age 2. She also mentioned that thyroid hormone is rarely implicated in obese young children, especially if they're normal stature. And remember, as we've talked before, TSH elevation is seen in 1 to 21% of obese children, often, and in teenagers, so it's often a marker of obesity and not true thyroid disease. And a lot of us don't routinely send a TSH on heavy children if their height is fine. There are other rare deficiencies that can cause early obesity, like growth hormone and Cushing's disease. You think of it if they're not growing well. Also remember that premature age anarchy is more common in obese children who tend to be tall for their ages with a bit advanced bone ages. Now, there's no guidelines yet for routine screening for comorbidities in young obese patients, but you can get lipids if there's a big positive family history, and you can check liver enzymes starting at age 3. That was new to me, but there is no utility to screen for A1Cs until they hit puberty or after age 10. In summary, most early obesity treatment is just trying to slow down the rate of weight gain. We should always preach hope and reinforce any positive lifestyle changes and focus on the good behaviors, not just fixing the weight issues. And then she talked about obesity screening and management, and that all types of diabetes, 1 and 2, seem to be increasing across the board. And remember, and this is really important, type 2 diabetes in younger people is much more aggressive with shorter times to morbidity, like vision issues, kidney issues, than in older people. The life expectancies, and cancers, the life expectancies is reduced by 15 years. So it's a lot different when you have a young person with type 2 diabetes than you have a much older person with type 2 diabetes in terms of risk, which, as we'll get to, is why the AP has recommended being more aggressive about treating this in younger ages and treating the underlying cause, which is the obesity. Now, we should screen all for type 2 diabetes with a fasting glucose and an A1C once a child is greater than 10 or hits puberty, whatever comes first. But remember, getting routine A1Cs in pre-pubertal kids, even if very obese, is not indicated at all. And please don't get insulin levels. During puberty, the natural insulin resistance increases, and levels do not correlate well with dysglycemia. So the definition of diabetes: A1C greater than 6.5%, fasting glucose greater than 126, a 2-hour oral tolerance test greater than 200, or random glucose greater than 200 with symptoms. So then there's pre-diabetes. It's an A1C of 5.7 to 6.4%, or an impaired fasting glucose of 100 to 125, impaired oral glucose tolerance 140 to 199. And in Delaware, these are seen by the Healthy Weight Centers first. Now with obesity, about 20% of youth and 25% of adults can have prediabetes, but 70% of the youth will regress to normal after puberty since their natural insulin resistance decreases. So stress that most of these teenagers with prediabetes will not necessarily end up with type 2 diabetes when they're out of puberty. So, metformin is still the first-line therapy for type 2 diabetes in children. You really want to keep them off insulin. GLP-1s can have a role, like liraglutide Victoza for 10 years and above, which is a daily sub-Q injection. So turning towards lipid screening, remember, a fasting dyslipidemia screening is now recommended for all children 9 to 11 and again at 17 to 21, knowing that increased triglycerides and decreased HDL is the most common pattern seen in obesity. I would add that if I have someone also with a very strong family history of cardiovascular disease, a parent who died of a heart attack, or multiple relatives, at some point I also get a lipoprotein A. Now, for elevated LDL, again, lifestyle modifications for at least 6 months, and then consider statins if the LDL is greater than 160, if not type 2 diabetes, or if they do have type 2 diabetes, then if the LDL is 100 to 130. And in Delaware, at least, LDL is above 160 or triglycerides above 300, see cardiology. Under that, they see healthy weight. Now, getting to that triglycerides, you want to reduce sugars, maybe over-the-counter or prescription omega-3 fatty acids like Levasa, if the triglyceride levels is 300 to 500. Hypertension. It's usually essential in these obese children, but you need to rule out other causes, especially renal, when they're younger, and always refer a child who's under age 12. ACEs and ARBs are first-line treatments, but remember, you need multiple visits to diagnose hypertension and make sure that the cuff size is appropriate. Then there's fatty liver, or MASLD, metabolic dysfunction associated steatotic liver disease. We should screen with ALTs in obese patients, again, starting at age 3. In Delaware GI season when they get over 80. The biopsy is the gold standard, but mostly it's now looked at. You can do an MRI looking at elastography or a fibroscan ultrasound measuring stiffness. Treatment is lifestyle modifications. There is a medication, resmetirom or Resdifra. That's a daily pill for this. Weight loss surgery and likely GLP-1s will be approved for this likely in the future in pediatric populations. But what's striking to me is that the number one cause of liver transplants in the United States is this fatty liver. And as a note, it's mentioned and we should call it MASLD. We no longer call it non-alcoholic fatty liver disease. But I have to say in the room, when I use the term fatty liver, sometimes that gets everybody's attention and they work harder at lifestyle management. And then there's sleep. We all know that obese kids can have increased obstructive sleep apnea. So ask about snoring, breath catching, daytime sleepiness, irritability, and refer to a sleep study if they have obesity and one of those symptoms. And yes, mental health with everybody, but especially overweight children, much higher risk of eating disorders. And then there's CNS morbidity, idiopathic intracranial hypertension, what used to be called pseudotumor cerebri. It's seen more in women. And if you think about it, if there's a new headache and vision changes or pulsatile tinnitus, often with an increase in body weight. So have these kids see ophthalmology and neurology. Okay, pediatric obesity medicine. And we all know the 2023 AP practice guidelines for severe obesity. It recommended that we should offer obesity loss pharmacotherapy in age 12 and older, and maybe for age 8 to 11. It was very strongly worded because they said we're losing the war on obesity, and that it tracks through childhood and adulthood and will not magically reverse. But I would note that in the UK and Sweden, Australia, their guidelines are much less strongly worded. Of course, we start with intensive health behavioral lifestyle treatment, IHBLT. Many of us are lucky enough to be near a children's center that offers healthy weight centers with exercise physiologists and nutritionists. But Matt and I realize that many pediatricians out there don't have the luxury of this nearby. GLP-1s, which have been used with diabetes as injectable pens and more now for obesity. But many peds PCPs obviously don't do that. But in the adult world, primary care is starting to do this routinely, and these pen devices are very user-friendly. So Dr. Crimmins made the point that if in your practice you wanted to do medication obesity care, you just need to designate someone who's passionate about it, who will give thoughtful assessment, exercise, nutrition resources, and strongly recommend that they could contact the American Board of Obesity to get boarded in obesity medicine, which is a great option outside of a fellowship. Okay, those GLP-1s, it's unclear if it will be a forever drug, but the morbidity and mortality of severe obesity in youth is clear. The GLP-1s and GIPs decrease insulin secretion, decrease glucagon secretion, slow gastric emptying, and reduce the food chatter. Now, specifics, there's liraglutide for weight loss, also called Saxenda. It's a daily sub-Q injectable for 12 and above in a multi-dose pen, and may be approved down to age 6 because studies are positive but not approved yet. And then there's semaglutide, which for obesity is Ozempic for 18 and above, but for weight loss it's called Wegovy for 12 and above, weekly sub-Q injections, multiple doses come with needles. I've had multiple patients on Wegovy. Again, to stress, Ozempic is not FDA approved as a weight loss drug. It's only approved for diabetes. And evidently, there's an epidemic of very wealthy, somewhat heavy people who have suddenly gotten prediabetes, so they're using up all the Ozempic, and that's why there's a shortage. Now, there's tirzepatide, which is a GLP-1 and GIP weekly sub-Q for greater than 18. And for diabetes, this is called Mounjaro. And for weight loss, it's called Zepbound. And I've had a few patients on this. The newest one is retatrutide, a triple receptor agonist. And it really helps with fatty liver issues and soon likely will be approved for weight. I think most of us know that GLP-1 data on weight loss and reducing serious heart problems are striking. Now, the contraindications and side effects, pancreatitis, if there's a family history of MEN2, also gallbladder disease. The main side effect, though, is nausea and vomiting, and Zofran can help this. But the biggest issue is cost. Liraglutide, $400 to $500 a month or much more, with huge insurance variabilities, sometimes covered by public insurance, better than private insurance. And she made a big caution not to use compounded versions of these drugs, where they often mix them with different vitamins, and just do not use them. Other obesity meds, phentermine, topiramate ER, which is Kysmia, which is a daily oral medication, 12 and above. It's a controlled substance. You can sometimes get headaches, blurred vision, tingling, mood changes. I've had a couple people on this phentermine. Other things people do, like metformin, is not FDA approved for weight loss, but it could be helpful, especially if there's PCOS or SGA driven, or if the weight gain is driven by bipolar medications. So her take-home points: GLP-1s are the most effective weight loss medicine in kids, but hard to get and expensive, so never promise it. And more options may be on the way. Some are pills, like orforglipron, which is not approved yet, but that would certainly be more easy than injections. And then finally, Dr. Mahmood talked about bariatric surgery. He mentioned that bariatric surgery for the most severe cases in adolescents is trying to reduce risks of atherosclerosis, diabetes, liver failure, and many cancers, especially organs surrounded by fat, which is breast, liver, kidney, stomach, and colon. And emphasize, which I think is really important, that regular weight loss is hard. Your body fights back. And it's usually not the fats in the diet that's a problem. It's the sugar. The sugar becomes fat. So low-carb diets work the best. And again, exercise is important, but to lose weight with exercise, it's got to be really intense. Just not sweating, but really burning off the weight. I would note, yes, that's true, but I do emphasize for all patients, but even those really heavy, that even 15 to 20 minutes of low-impact exercise 3 to 4 days a week where they get either sweaty or their face turns red or a little shorter breath is really good for your heart. He emphasized that bariatric surgery in teens and young adults is safer than gallbladder surgery. It's done laparoscopically. It's been shown to be more effective than medical therapy for severe obesity and type 2 diabetes. And there's two approaches. One is the laparoscopic sleeve gastrectomy, where they take out part of your stomach. This can result in more reflux. That's the big issue. Or the Roux-en-Y gastric bypass, a more involved surgery where they create a small pouch stomach and it's directly attached to the upper small intestine, bypassing most of the stomach and the proximal intestine, which is why you can sometimes get more vitamin issues. Neither surgery is reversible. As an aside, there used to be an adjustable gastric banding surgery that they could adjust it. I remember that from years ago. It had lots of complications. It's really not used anymore. The long-term weight loss with both of these surgical techniques is pretty incredible. 29% weight loss 8 years later with gastric bypass, and 27% 8 years later with sleeve gastrectomy. Side effects, again with those, especially that Roux-en-Y, vitamin deficiencies, B12, iron, calcium, vitamin D, and then reflux with that, but specifically with the sleeve gastrectomy. And also possible decreased bone density, so you really need to supplement and watch that closely. The indications for surgery, BMI 35 with morbidities, or BMI 40 and above with no comorbidities. And he wanted to emphasize it's not a quick fix. You must succeed medically also. So after the break, you will hear the epic surgery versus medication for severe obesity in adolescents debate. And there'll be a lot of talk about insurance coverage, which is really maddening, and about how perhaps sometimes a combination of the two, whether they do medication first, and if it's not working well, at least if they lose some weight, the morbidity from surgery is less, or if they do surgery, but they start gaining weight, then they can use some of the GLP-1. So I hope you enjoy the epic debate. And Matt and I will be back very soon. He'll be talking about his daughter's wedding, and I'll be talking about my first grandchild. One last thing. During the debate, you'll note that I made a crack about my 92-year-old mother asking me to find Ozempic for her. Please, 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 if you ever see Lila Rose, do not mention that. To our debate where you guys were doing polling everywhere, so you guys are going to vote before and after the debate on a couple cases, and we'll see if the needle moves. And it's really important because there are prizes. So between those two, because they're acting like they're really friendly, but this is a fierce debate between the two of them. So pharmacological versus bariatric surgery for pediatric morbid obesity. Playing Jane Curtin will be, who knows Jane Curtin? I'm old, okay. Will be Nancy Crimmins, and then Dan Aykroyd will be Asif Mahmood. And they had said that they either could argue either side, and by kind of a coin toss, Dr. Crimmins will go first. Just 2 years ago, I did a hot topic paper in the beginning about how much these medications have grown. I know a few people in the room said they're prescribing it. 2 years ago, only a handful of people had any patients who were on these medications. So raise your hand if you've had patients on these medications or get bariatric surgery. That's a huge change. So this is headlines, and they're putting this together the last 6 months. In December, bariatric surgeons being put out of work by GLP-1 drugs. Patient who had no luck with GLP-1 drugs found final success with surgery after insurance rigmarole for 3 months. Wegovy use up in teens 50% as obesity crisis worsened from June. And then this month in the Journal of Pediatrics, a study from 2021-2023, bariatric surgery utilization increased in adolescents while decreasing in adults, especially in underserved populations. So, last visit a day, you get these double teens at your last visit a day. It's like, oh my God. So 16-year-old Jason, an 18-year-old boy, 18-year-old Taylor, girl, Kelsey, their younger brother, Travis, could not come to the visit, who are here for their single parent mom. Both kids struggle with weight issues since toddlerhood, as had mom, and have participated in the Healthy Weight Wellness Program the last couple of years at the local children's hospital. And I know not a lot of you, I do, but not a lot of you have a program like Dr. Crimmins and Mahmood that close. Neither child has been able to stick with exercise and nutrition goals. 18-year-old Taylor, 5'5", 230 pounds, BMI of 38.3, particularly suffer with self-esteem issues, has prediabetes, is on metformin, has an A1C of 6.3, moderate hyperlipidemia, and a normal ALT. Her younger brother Jason, all 10 or 5, 5'8", 273 pounds, BMI of 40.3, normal A1C but elevated liver enzymes, LDL of 130, also really distraught about his size. Mom understands that you're not an expert, but she trusts you. They trust us. We've seen them since they were born. The medical team has recommended either surgery or medication treatment for obesity, and she asked your opinion. Should 18-year-old Taylor, with this BMI, with self-esteem issues, and prediabetes, start pharmacologic obesity meds or have bariatric surgery? What would be your best answer? It's A, you would say do the meds. The results have been amazing. B, you would say do the meds. There's too many risks to do permanent surgery on this 18-year-old young lady. C would be do surgery. It's this one-time intervention, likely great result, proven track record. Or do surgery. There's no long-term data on the safety and side effects of these new lifelong GLP-1 medications. Or E, neither. Continue stressing lifestyle changes and treating comorbidities as they arise. Okay, now we have younger brother Jason with his BMI of 40, normal A1C, liver enzymes, elevated LDL 130.
Let's get ready to rumble!
Okay, so we have benefits versus risks. Nancy Crimmins, the Franklin College Grizzly, versus Asif Mahmood, the University of South Florida Bulls.
At least we have fun mascot. So I'm going to argue for weight loss meds, and here are my arguments. These medicines are overall safe and well tolerated. He just went through this whole lecture of some of the things you can see with weight loss surgery, and I think he went over, Rob went over some numbers. The reason why people are taking to these medicines is because they're fairly quick and effective, and people are nervous having their anatomy changed. And you have the ability, surgery is all or nothing. You have it, or you don't have it, but these meds we can ramp and see effects. So there are people who are very successful on very low doses of the medicines. Actually, those are the ones I always tell them, like, you clearly have a deficiency this medicine is working towards. So you have ability to play with it a little bit more. It's not the same surgery group. We've had 2 deaths in our hospital in the last 5 years with weight loss surgery. One was not related to the surgery. It was related to an airway issue. He had a leak would have been easily fixed, but when they took him back, they couldn't get an airway, and he died. Because these kids are heavy. They have other issues related to the surgery. And the other one was a leak. And it just happens. It doesn't happen often, and we have a good surgeon, but it happens. I already showed you some of this. This is tirzepatide, I think. But they can be very effective in terms of losing weight. So even though they may not get you quite to what bariatric surgery is going to do, you don't need a lot of weight loss to have a metabolic effect. And again, he's right. That's what we're trying to do is to get disease better and to make it go away. You guys have always heard that 5 to 10% of weight loss can make a huge effect. And it's true. It does metabolically. Not in everybody, but in some. Accessibility and time, there's a wide range of providers who can prescribe these medicines. So if you're in a more remote area, it's hard for patients and families to get to surgeons who operate in teenagers. This is something that a lot of different providers, including yourselves, could write. You go home with a prescription, you start immediately, so you're not missing school, you're not missing work as much. You still should come and do lifestyle things and see your doctor. So you do miss some, but not as much. We talked about this a little bit. No change to the anatomy, although surgery is overall safe. But I think the biggest thing to me on why in our hospital surgery has gone down and meds have gone up is before we really didn't have great meds to use in kids at all for any of it. And I did refer a lot more to surgery at that time. But, we talked about type 2 diabetes. We can use GLP-1 receptor agonists anyway, a standard of care for that disease, SGLT2 inhibitors. So we're not I hate the word burden, but it is, having these kids take multiple insulin injections a day. It's just those days are gone for most of the kids. Dyslipidemia, statins have been used in kids for years now. They're safe, they're cheap, it's once a day. Essential hypertension, again, those meds are safe and cheap and used. So there is, of course, the more meds you put on, the harder it is for people to do it, and that does change things, but you can have a safe, healthy life on these medicines. There's actually a study coming out that Children's has participated in called STOMP. They're actually the lead center, but it was comparing medications and surgery in kids for type 2 diabetes. So it wasn't how much weight you lost, but could we keep your A1C in the same place as surgery? And the answer is you can, but the criteria was pretty aggressive med titration. So if you weren't under 7, you weren't under goal, you had to change. And the families had to be dedicated to doing that. But we can keep the control for diabetes a lot better on meds now. And then again, obstructive sleep apnea, now tirzepatide's approved. So we have other things we can do for some of these conditions. This was brought up by Rob in a question, but I think it's really important. So there's better outcomes if you reduce weight prior to surgery, so you might as well try it first, and then if they have a lot of success, great. And if you don't get to your outcomes, then you can refer to surgery. And then again, when they do hit that plateau with surgery, sometimes we are starting GLP-1s. There was some teen data that came out recently in a small number of kids. Up until recently, it's been adults that we have that data on. All right, so for Taylor and Jason, I have to say my husband's name is Jason Taylor, so this threw me off when Rob sent me this question. So Taylor's an A1C of 6.3% on metformin. She probably has diabetes. This is something I get asked a lot too. I don't like to take kids off metformin to prove it, really. But if he did, metformin usually lowers 0.5% to 1% A1C. She probably already has type 2 diabetes. So adding that GLP-1 receptor agonist will preserve the beta cells and treat her diabetes both, and weight loss will be a positive side effect. I wouldn't want to wait and have her diabetes get worse. So I would go ahead and do that. Now, I totally agree with the mental health piece, and whoever asked that, both kids have in their question an aspect of that, so you definitely want to evaluate for depression, anxiety, and get mental health services for her in some way. Jason has MASLD and weight. He really doesn't have a whole lot else. So this is a kid where I would do the imaging to see how bad the fatty liver is if he hasn't had it, and is it scarring, or is it because if you have scarring, you might want to do something more quickly, like surgery. But if not, the GLP-1 receptor agonist will definitely help. He doesn't need lipid meds at that LDL unless he had diabetes. He also has a lot of distress, so that's something you're going to want to tackle. And then it said both kids or have been struggling with lifestyle changes, I would want to delve into that more. Why? Is it because they're not seeing success with it and they're just frustrated? Is it other barriers that you could address? So when I say meds, I would do meds, but I also really investigate these things. And sometimes you get a lot of buy-in in the kids by showing you're trying to help them and that you care. They've participated in a weight management program. It's not like they haven't been listening to this stuff. And sometimes just getting some of the food noise cut down and then getting some success really motivates these kids to look at other things that they're doing in their behaviors.
Asif knocked into her when he walked by her just now. Just want to point that out.
That's how you win. So I'm going to be surgeon today. But like she said, I do both. And there are instances where I feel strongly either way. But I'm surgeon today, so I don't have any disclosures. And like I said, the urgency is the way I would approach these patients. So medications, just to remind you, 50-50 shot, may work, may not work. You stop it, weight will tend to come back. So I set those expectations with my patients. This is the AAP, surgery is more effective. A lot of it is always like type 2 diabetes and comorbidities and obesity. If you tag a comorbidity, that's when surgery is really beneficial and indicated. And in these two kids, that's really what we're seeing. Again, hypertension reduction, diabetes reduction, life expectancy. So that's the way I would look at it. In these kids, it's like my first case. I want to reset the clock. Where every day that they're overweight is end organ damage day. We're talking about long-term cirrhosis, heart disease, diabetes, leading cause of end-stage renal and dialysis. So that's the way I look at it. This last piece I do want to talk about because this is probably going to force your hand. Insurance covers surgery for kids, but it doesn't cover meds. It blew my mind. And it's the opposite problem I have in adults because adult surgeons don't like to take Medicaid. So in general, I have a harder time getting surgery for my adults. But for kids, I'm just like, would you just want me to do the surgery? Like, I argue with the insurance, and it takes months, and just we don't get the medication. But that is something to consider, is that these are expensive. Is it a forever medication? Is it just, I don't want to say easier, but like sometimes you have to think about how sick is the patient, how much I need that weight off quickly. And so that's the way I would think about it. This is actually Endocrine Society. I was glad I found it. So type 2 diabetes, private insurance denies 54% of GLP-1s. Medicaid actually, interestingly, only denies 27%. But the moment type 2 falls off, they deny 69%. Private insurance doesn't really care if you're sick or not. It's just they're expensive. So 55%, I don't want to pay for this. I don't care. Like, I don't really want to go through with this. Medicaid tries to be reasonable, but, you can imagine the financial incentives are different, but the end results is often the same. Private insurance wants to maximize profits, so max out premiums, lower benefits. Medicaid wants to do what's right for their citizens of the state, but they're short budgeted. They just don't have the funds. A lot of my complex care kids, I have to argue about 24-hour nursing, but Florida Medicaid just doesn't have money, so a lot of times that's the way I think about it. So what I like is these kids already tried a structured program, which is important. They did try, they went, and these are like very frequent visits, highly involved pediatricians that have worked with it, but despite that, they have these complications. So for Jason, summary, 40.3, has fatty liver and high cholesterol. That, to my mind, equates to cirrhosis and liver cancer eventually, and heart attack, strokes. Taylor, prediabetes. So prediabetes, in my opinion, is like in the same spectrum of diabetes. What I saw like during my medicine boards, the reason we talk about 6.5% is that's where the complication rate spikes. So if you look at the A1C, the incidence of retinopathy, it's like fine, 6.5%. Diabetic eye disease jumps up. So that's sort of why the 6.5 is what I've seen, is that the complication risk. But even then in adults, we try to get them under 7. Which is kind of a weird, like we've seen in adults, if you try to shoot below 7, they get more hypoglycemia. But that prediabetes, in my opinion, this is like the same spectrum. So this kid is at increased risk of retinopathy, dialysis, and then obviously heart attacks and strokes. Both meet criteria. They're at least 35 BMI with a comorbidity, and then one of them is 40 alone So they both meet criteria, so you don't have to be worried about that. Again, in my opinion, they're probably not going to GLP-1. I probably will try, though. I want to maximize, like I said, I want to get them ideal for surgery. I think in my head, if they come to my program and they've already tried these structured programs and lost weight and didn't lose weight, I think we're probably heading towards a surgery, really. But I know they're probably not going to get the meds. And they will progress to end organ damage. We're seeing these earlier. I have younger adults getting colon cancer earlier despite recommendations for colonoscopy. So we're just seeing these things happen earlier and earlier. And I actually have patients, by the way, in terms of safety. I have 90-year-olds who had bariatric surgery in the 90s, like 1990s, and they're 90s now.
Okay.
Sorry.
Sorry, it took me a minute.
Although technically the idea is that you can do it in older patients. The risk of it outweighs, the benefits outweigh. But I have patients who got them when it was all hot. And, in the 1990s, laparoscopy was new. These were out there. I have patients in their 70s, so I do see it. They do survive, make it out there long enough to get other problems, but usually not because of obesity. But that's the way. It's diabetes and fatty liver. That's the urgency in my mind. I need to reverse it. I need to reset the clock. So I think these kids will probably get surgery, at least if they come to my clinic. And then that's the remission rate. That's the A1C benefit. Oh, I didn't talk about this. The BRAVE study specifically addresses fatty liver. With post-bariatric surgery, there's a significant decrease in fibrosis score and a decrease in ALT-AST. So there is data to support that. And actually, a lot of our transplant hepatologists are doing weight loss. Like they're doing phentermine, they're doing like GLP-1s, and they're citing articles in there. But obesity is really infiltrating into all the specialists, our cardiologists. I did want to make a note that what we're seeing is that there's probably a microenvironment of high sugar that's causing all these organs to fail. You may not have diabetes, you may not have prediabetes, but all these meds that lower your sugar is preventing these diseases. Heart failure, doesn't matter if you have diabetes, Jardians, SGLT1, T2s are indicated, GLP-1s are indicated. All of these disorders, CKD, they're like the hot new drugs, both of these classes. It doesn't matter if you have diabetes. So the idea is there's probably some sugar microenvironment that's causing problems to everything. Long story short, they're younger, they're more time disease. It's like smoking at a younger age. And then you're going to avoid polypharmacy because we don't know how long these patients are going to be there. Are they going to get gastroparesis after 30 years? I don't know. All right, thank you.
Last rebuttal? Or not?
No. He's right, you guys. Like, it depends. I just a terrible rebuttal, isn't it? In my area, Medicaid will pay for bariatric surgery because ultimately it's cheaper for them. It is one surgery cost, and a lot of these things go away, so I feel like I'm arguing for your side. I like to argue as a purist because I think if we just say that, like, the real reason is these meds need to be cheaper and they need to be more accessible. He's right about the denial for type 2, kind of. That's if you just write them first. If you have to prove that you're like failing metformin. So what could happen with Taylor is, say she had diet, her A1C was 6.5 and she's on metformin. It is possible that I will write a GLP-1 and they say she hasn't failed. She's below the treatment goal of 7%, and we're not going to pay, for this medicine. So, but it just makes me sad because those medicines will preserve beta cells, and that's been shown. So I really think the main take-home point is these drugs, if you go to Europe, are so much cheaper, and I think we still need to think about weight in terms of what's right and wrong. And I don't know if anybody out here can fix healthcare in America, please. I'd love to hear it, but right now it's cost.
I mean, I'm a medical doctor. I don't want to do surgery. I agree. I would try so hard to do these meds first, but it's like like bashing my head against a wall sometimes. One of my partners asked an insurance company at a conference once, like, why don't you cover it? Again, it's like a cost analysis. On average, patients don't keep their insurance more than 3 years. They don't reap the benefits from the GLP-1. I know, like,
That's
it just,
right.
but it just put it in context in my mind that we know 20, 30, 40 years down the line it'll help the patient, but it didn't help the insurance. And so that's why a lot of this is the way it is. I
Well,
agree.
and
I
it's-
mean, both ways, yeah.
The other thing is it's not the insurance company itself. It's not like it's Anthem, Humana, whatever. It's the employer has to eat some of that cost. So if you look at hospital systems, and obviously all of the hospital systems in Cincinnati have weight loss programs and people who do that, there's only one hospital system in Cincinnati where you can get these meds for their employees and for their children. So it's just mind-boggling, really. But healthcare, big hospital systems are trying to save money in lots of ways, and it's just one of the ways they do it, even though they feel like it's the right thing to do. So it's hard.
Okay, we have Ernst & Young back there who are tabulating everything as we speak. I had to laugh at that issues about the 90s because I talk to my 92-year-old mom every day in her independent living, not assisted living. You have to make that distinction. But a week doesn't go by that she doesn't ask me about obesity meds and if I can get them for her. So... So we have a result, and we, 10 years we haven't had this. We do have a exact statistical tie today in our debate. So give them a hand. So it's a little bit like Oprah, which is where my mom gets her obsession with obesity medications. So Dr. Mahmoud gets his University of South Florida. He's a 7-year med. And I couldn't find a field hockey soccer uniform, but I do have the Franklin College Grizzlies. For Dr.
I'm impressed you got this very much. Thank you.
And thank you all. Thank you to our participants. They were great. Podcast Pediatricians Productions. All rights reserved.